Yes, good afternoon, Professor Katrin. Thank you very much for being on the podcast. This is the All Pulp No Fiction Dental Podcast, and we are here at the IDS. How's your experience with the IDS so far?
Yeah, first of all, thank you very much for the invitation to join the podcast. Great
Thank you.
pleasure.
Thank you very much.
IDS is always like a great event. You see so many colleagues, you see so many friends, and you can do networking, you can exchange ideas, and I think it has grown again when we compare it to the IDS 2 years ago.
Yeah, maybe 2 years ago was like, especially with the Corona thing happening.
Yes.
Yeah. So today I was at your lecture at the GC booth, and I found it very interesting. Like your subject is MIH, or molar incisor hypomineralization. What got you interested in this topic to begin with?
So, to be honest, it was a coincidence. So, I was working at the Department of Pediatric Dentistry at my former university in Germany at the Martin Luther University Halle.
Yeah.
And I got to see a child for emergency. And the child was presenting with pain. And so I was expecting to see caries. So when the child was telling me I cannot really eat, I cannot really drink, and I have so much pain in my teeth, I said, okay, open your mouth. I'm gonna see what the problem is. And I did see very well brushed teeth, no caries at all. But what I mentioned was, and what I realized was that all four first permanent molars, the posterior teeth, showed heavy discoloration and started also to break down. And the parents didn't really notice that. So I was the first one showing it to them. And it was the first time I was seeing this clinical picture. And so I got deeper and deeper into that topic. But at that time point, we didn't see so much children with it. So it was not recognized. It's a very young disease. So we know it for 24 years now. And if you compare it to caries, which we know hundreds of years,
Yeah, pretty young.
yes, it's a very young condition. And this is, I think, why it's also so interesting, because a lot of is going on in the research field for this condition in so many different topics, because right now we do not know the causes yet. We only know it's prevalent around the world. We are still searching for better therapy concept, maybe to heal the enamel, although we know how to take care of the children, but we want to get better and better in it.
I see. And for people who are listening right now, can you give us a simple definition, a simple introduction about the condition?
Yes.
So, what to look for example?
Yes. So it's called MIH. MIH is the abbreviation for molar incisor hypomineralization. So to start with the last word, hypomineralization, it means that you have a defect, a qualitative defect, only a discoloration in the enamel. And what is also in the term is molar and incisor, because you need at least one molar to be affected.
Yeah.
And the incisors can be affected as well. They do not need to be. So it's always about these two pairs of teeth. And this is why the disease is called molar incisor hypomineralization.
Is there, like, from our understanding, like you've been involved in this research for a long time, do we still understand why is it happening, or like it's still a little bit unclear?
Because this is the most burning questions for the parents as well. Why does my child have MIH? And it's more or less in the direction, what did I do wrong? Is it diet? Is it nutrition? Is it wrong oral hygiene?
Yeah.
It would be nice if these would be these two factors would be the reasons. But the problem is, we diagnose MIH when the tooth is erupting. So it's beginning of school age. The first permanent molars are erupting when the child is 6 years old. We cannot diagnose it earlier. Although if we would have an X-ray, we would always see a good shape of the tooth, the normal shape, because it's a qualitative defect. It's only a discoloration of the enamel. So what I try to make clear to the parents is that they have to understand this tooth is not mineralizing, is not forming just weeks before the tooth is coming out into the cavity. It takes place years ago. And we know for the first permanent molars and for the incisor, this is a time frame starting shortly before birth and going into the first years of life. And this is what parents need to understand as well. The mineralization process of the enamel is not happening in weeks, in a few weeks. It's taking years. So we are looking back to a very large time frame, need to look back what might has happened there. So the first etiological studies were focusing on questionnaires, asking the parents where we have diagnosed MIH, what might have happened in these years, in the first years of life around birth. And right now we know that it is connected in a lot of cases when children have been ill in the first years of life, childhood diseases like asthma, pneumonia, but also otitis media and other childhood diseases, or children have taken antibiotics. Nevertheless, we have to realize that childhood diseases, antibiotics were also taken 30, 40 years ago when we didn't know the condition, and it's increasing. So first of all, these two factors are not the only ones. Also, what is discussed, maybe hypoxia at birth. We also have parents saying, no, none of these factors happen, but the child has MIH.
Still
so
has
this
it.
is a big enigma. So what we have understood right now, it's multifactorial. It's not one factor. So probably something from the environment is also there. And the factors that we are discussing right now, it's only about increasing the odds to get MIH. So not every child that was ill automatically has MIH. So it's very interesting. And now we are diving more and more into prospective studies, children who have just been born, to follow them the first years of life and maybe see what is different compared to healthy children. A lot of laboratory and animal studies are going on. So, but I think it will take us a few years.
And about the prevalence of it, is it also like from the map that you showed us, like it's basically all over the world?
So right now we know it's happening in every continent. It's a more or less prevalent condition. On average, it's every 7th child that is affected worldwide. So we are not talking about a rare condition. It's a little bit different if you go into the different countries, but nevertheless, it's prevalent.
I see. And what are the main challenges in dealing with, obviously we're dealing with kids, so that's a challenge in itself.
So the clinical challenges beside dealing with kids is you can experience very rapidly post-eruptive breakdowns. So it's discolored, the tooth is erupting, and it's breaking down very rapidly. Second is the teeth can be very hypersensitive. So children are in chronic pain. If there's pain, they do not really want to brush the teeth. So there might be also niches from the post-eruptive breakdown. So plaque can accumulate very well. And then this might lead to caries as well. And what we also know from post-eruptive breakdowns, and then when we want to do restorations, that the adhesive protocol needs to be adapted because the adhesion to the porous enamel does not work quite well. So we also see loss of fillings.
I see. And regarding, the research that you were doing and the treatments that are available now, how did the research affect, I saw you talked about a few methods that you can use to treat the patient.
So interestingly, in MIH, we have learned over the last 20 years a lot in practice. And it was a very hard way to see what is working, what is not working. And in a second step, now these treatment concepts, what we know that they are working quite well in practice, we need to get evidence for them. So the second step is right now to put all of the knowledge now in studies and to gain evidence. But nevertheless, with clinical studies, it's always a problem in MIH. MIH is not the same in every child. It's very variable from very mild forms to very severe forms. So if you do a clinical study, you need children having the same grade, the same severity, no other problems. So we do a lot of multi-center studies, of course. But it's a working project, and I think we will get much more evidence in the future. Nevertheless, right now we are in the position when we are talking to the parents, explaining the disease, that we can say, okay, we can help your child. We have established therapy concepts, and we know what is working and we know what is not working. And so we can guide you and make an individual plan for your child.
I see. And regarding this point, what is the role of the child is very difficult to, put this responsibility on them, right?
Yes.
So what can we expect of the child, and what can we expect from the parents?
Yes.
What's the role of the dentist in all of this process?
So like everywhere in pediatric dentistry, not only in MIH, I think it's the main goal is to gain the trust of the child and the trust of the parents, because if the parents trust us, they are also relaxed, sitting relaxed in the chair when they are accompanying the child. And we have some nice behavior management techniques, of course. Nevertheless, in MIH, in the very severe cases, we have to deal a lot with very sensitive children. We always describe it like there are sensitive teeth in sensitive children, which is another level. But nevertheless, if they gain the trust over the time, it's possible to treat them and also to give them the best therapy.
I see. And regarding the dentists, is there anything that you can recommend to them when dealing with these cases?
So I think every dentist should recognize that in children beside caries, we have another problem. We have the problem of chalky teeth of MIH, which is very prevalent. So every child coming to a checkup should not only be examined for caries, but also for discoloration, for probably MIH, so that it can be diagnosed as early as possible. And that then, in a second step, the child can be included in a prophylaxis program, and the therapy concept can be chosen for the child regarding the needs of the tooth. And secondly, not only to start examining children for MIH that are getting into the mixed dentition, but also in the primary dentition, because what we have also learned over the last years is that hypomineralized teeth can also occur in the primary dentition, and then it's mainly the second primary molars. So they should be examined for this as well.
I see. And using the use of fissure sealants or for high fluoride, toothpaste, something like that, is it particularly important in these cases also? Is it recommended?
Yes, so regarding prophylaxis, they should be included in a tight prophylaxis concept, which includes at home the use of fluoridated toothpaste, and in office they should get 2 to 4 times a year fluoride varnish for caries prophylaxis.
I see. So any last words that you want to keep, the dentist should keep in mind when dealing with MIH cases? So a takeaway point, basically.
So, I mean, my main message is everybody should be able to diagnose MIH, to see it, and then to know the different stages, the different severities, the needs of the child, and to know that we have very established therapy concept that we can help the child.
I see. Thank you very much, Professor.